So let's go into week 5 and let's go into the PowerPoints. We're doing chapters 40, 42, respiratory and cardiac. We're going to start with respiratory and then we'll do a cahoots. Then we'll do cardiac and then we'll do a cahoots. The group before you, as I was the first group that tried this, doing part of the PowerPoint, doing the cahoots on that section, and then coming back, finishing it, and they loved it. So after it's done, I want to know what your opinion is on getting it done like that. I actually think it's good. I actually see differences in quiz scores, exam scores already. I see a difference by just doing it this way. It sort of solidifies in your brain that concept that I just talked about. And now you got a question. Let me answer that question, right? So respiratory infections, we have upper airway, lower airway, right? We know that upper airway is all about that mucus in the nose and the children get, and they always have mucus and they never blow their nose and it's always running and crusting. That's just kids. That's what they do. The lower one is more of your bronchus. This is your asthma, your pneumonias and stuff like that. Now, children, most of the time, upper respiratories are going to be a viral infection. Okay. Rarely, it's actually bacteria. You take your child to the pediatrician. This is a common complaint I hear. And they looked at them and they did a throat culture or this or that or a flu test. Everything's negative. They said, oh, he has a virus, send him home. And he's still sick. Well, if after 3 days a child is still sick, then they'll place them on antibiotics because up to that point, it's just telling you it's a virus. Now, one of the viruses that we think about with children is called RSV, respiratory syncytial virus. For you and me, that's a common cold. It doesn't hurt us. I mean, it's just the normal thing. Whatever virus it is you just feel horrible, right? Infants, think about them. They have a hard time sucking, swallowing, and breathing. Now you put mucus in their noses with this RSV and a little fever, and they feel miserable. Remember, they're obligatory nose breathers. So let's put some mucus in there and let's try to breathe through the nose and suck and swallow and feed. It's not going to happen because they need the airway. So when you see a child with RSV, the thing is to clear the airway, making sure they're sitting up good, and then to feed them that way because these kids do struggle. Other children, as they get older, it's not as bad. Yes, they feel horrible, but it's the infants we worry about with RSV. As we go further, I'm going to discuss a immunization that we give monthly, not once, monthly immunization, only the first year of life. It's from winter to early spring. And in Florida, it's hard to figure out when that is, but they just give it for the first year because we don't know winter and summer. Of course, up north, you all know it better than we do down here. But we do give it, and these are for children that were maybe premature. They have other immunosuppressive disease, cystic fibrosis, sickle cell, cystic, all of these things. We don't want them to get that extra virus because they can't even handle what they have already. So we give that immunization for the first year of life. And then after that, they can fight it off, basically. Because remember, once you get a disease, you tend to build up antibodies and antigens for it. Now, on that note, let's look at infants. When they're born, mommy gives them all their good stuff, right? They've got all their, infections are controlled by mommy, their antigens, antibodies have all been passed over to that baby, but they don't stay there. They tend to go away after about 3 to 6 months. And that's when we start to see these infants getting sick that first year of life because they have not gotten sick. Mommy stuff is wearing off and they haven't gotten all the immunizations yet because we know as we get older and have diseases, our immunity increases, right? So infants, we have to be the most concerned about with fevers and getting sick. To tell you, an infant less than 3 months old going to the ER is a high level red chart. It is one of the highest levels because these children have no immune system. They're about to go into shock and they could go respiratory arrest and die. Really, 0 to 3 months. Fever is very serious. After that, we know the body has a little bit of immune in them. Plus, they've gotten those initial immunizations. Think about it. 2, 4, 6 months. We load them up like crazy, don't we? It's because mommy stuff is going away. One of the most common things we see in children is otitis media. Let's think about it. What happens? Well, children don't blow their nose, as I said. The mucus goes there and it goes wherever. It drips down, they cough. Luckily, maybe they blow it out, but it goes up those eustachian tubes. They are short, wide open, and straight. And that mucus needs a place to escape to. So, areas of least resistance up to the eustachian tubes, and now you have ear infections. Now, ear infections, how do we treat them? Well, everything in the mouth is staph, all right? You have it all the time, whether it's MRSA or regular staph. It's just common that we have germs in our mouth. So when it gets into the ears, it's not used to those germs. So we need to place them on antibiotics. Augmentin, otitis media, pneumonias, great drug. Augmentin would be that first line antibiotic choice that we did. Of course, making sure they finish the whole thing so we get rid of that whole infection. Now, there are kids who have chronic ear infections, and that can hurt the hearing, right? If we allow that to occur. So, what they do is a surgical intervention, they put tubes in. I actually have a tube in this ear, and I've had it in. In fact, 2 years I had bilateral tubes. I have this chronic sinus and ear stuff that goes on. So, the old lady has tubes in her ears, and I've had it done not under anesthesia. Would you like me to tell you what it felt like? You're in the doctor's office. They have a stethoscope, they look in there and they numb it. Okay. So you don't feel anything, but you can hear, because it's in your ear, when they cut the little tympanic membrane to drain the ear, you can hear that. And then they take a suction catheter, put it down in your ear and go. That is scary. And I didn't want to move because I was so scared, right? And then they put the tube in, it doesn't hurt. Now, that whole thing takes a couple minutes, but children would never sit there. That's why they're put under anesthesia and they're knocked out. It's almost like a brief, it's like 5 minutes and it's done. So I already said that. So, what do children look like when they're sick? We've discussed it a couple times, but let's go over it again. Kids who don't feel well could vomit once. They could be sitting in the corner, right? They could be not eating, not drinking. And what would we see? Well, sometimes it's that ear. Now, they're going to tell you which ear hurts. I like when they take the left hand and they go over and they point to the right ear and they go, this is the ear that hurts. It just breaks my heart. Or they take and with the other hand, it's not the same hand that they do. And they will tell you which ear. I mean, even young 2, 3-year-olds easily will tell you what they hurt. Children could have fever or that neck pain, yes. Not eating, coughing, noses, that all that rhonchi because of all that upper airway junk that these kids don't blow out. So, what is our goal? What do we want these kids with respiratory problems to feel like? We want them to breathe easier, want them to rest. We don't want them to give infection to anybody. I mean, they know how to put their arms up now. I mean, with COVID that came out, everybody got into infection control and covering the cough. And, so kids now know what to do. I mean, I didn't know what to do when my kids were younger. They didn't know how to do stuff like that, but today it is. Now, we want to reduce that temperature because once the fever comes down, the kid acts like they're not sick at all and they run around, and then you could give them fluids. Because remember, fevers have insensible water loss and they're going to get dehydrated. And if they're sick and feverish, they're not going to want to eat or drink a thing. Like, get it away. They won't even try. Fever comes down, now you can hydrate them, which is what we want. Now, infectious mononucleosis, it's not a big deal, right? It's a kissing disease. It is a herpes-like Epstein-Barr. It's a virus. It's a virus. How do you treat viruses? Any virus, pneumonia, any virus. Rest, fluids, antipyretics. That's it. Rest, fluids, antipyretics. That's how we treat infectious mononucleosis. But listen to this. Mononucleosis presents with a bad sore throat and that flu-like aches and body pains all over the place, swollen lymph glands, and your liver and spleen could also be swollen up, and you might have a rash. So what happens with these kids? They go to the doctor. Let's say it happens on Monday. They go to the doctor, and the doctor goes and does a strep throat, does a flu, does a culture, negative, 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 negative. They go, oh, you have a viral pharyngitis, the inflammation of the throat, and rest, fluids, antipyretics. 3 days later, this kid is still sick, complaining, aches and pains, miserable, takes him back to the doctor. Well, they'll probably retest all of the flu, the strep, the culture, just because, well, maybe it wasn't long enough that it wasn't positive enough yet. That's what they say sometimes. Well, it's still negative. So they said, well, we don't know what's going on, but it's been too long. Let's put them on an antibiotic. On Saturday, so this started Monday. On Saturday, they come into my emergency room complaining of all these things, tells me the story. So I already know what's going on. Sore throat, flu-like, everything negative still continues. What do we need to do to diagnose this child? Well, we don't need to do any more cultures or anything. We know that's negative. So we need to draw blood. And that blood we need to look at is CBC. Why is CBC? The white count. Is it viral, normal white cells? Or is it bacterial, elevated? And then you're on the wrong antibiotic, right? Well, you're also going to do something called a monospot test. This monospot test is just to say, do you have mono? And it's going to come back positive. So now we know how to treat this child. It's mononucleosis. It's an herpes-like Epstein-Barr virus. So fluids, rest, antipyretics. But this is the most important thing about mono. I told you that the glands get swollen, especially the liver and the spleen. So we need to tell them no contact sports. I have 6 brothers. So if I had mono, they were told not to wrestle with me on the floor because I was always getting beat up, because that's what families do, right? Also, no contact sports, no PE, and you need to get clearance from your pediatrician in about 3 or 4 weeks so that you can go back to playing PE. He has to check you first. Well, I had a boy. I'll never forget this child. I tell the story every term. He was either 8 or 9 years old. He came in with his father. The story was exactly like I just told you. Sent him home. The physician was a great physician. Told him the most important thing was just the symptomatic treatment, fluids, rest, antipyretics, but no sports. Protect the abdomen. That spleen, the liver were like big balloons and they could burst. Be careful. 1 week later, I am the primary trauma nurse on duty, which means any helicopter, any trauma that comes in, I'm the nurse in charge to document and to keep that thing going correctly, making sure I have what I have. I get a call. 8-year-old boy in the Everglades fell off an ATV. It was that boy. He came in dead on arrival. I'll never forget him. Excuse me. Oof, I do that sometimes. Okay. So if y'all can save one kid, please let them know about no contact sports, okay? Protect that abdomen. Okay, bronchitis. Bronchitis, I think, is one of the most annoying things there is. This is when you cannot sleep. You have this dry, non-productive, hacking cough, and it's really bad at night when you want to sleep. And you can't sleep, right? So we will be getting, and you usually don't have a fever with it. Although you will see most of the adult people order a Z-Pack for bronchitis all the time, and cough medicine, right? Or maybe a Medrol dose pack for swelling. I mean, this is the adult thing that we do. For children, what we do is we'll give them acetaminophen or ibuprofen. They're coughing. They probably have achy chest pains and whatnot, right? If they have a fever, but usually not, okay? And then humidity. Now, how are we going to get humidity to these children? Well, we can put them one of those vaporizers in the room, if you're home, but in the hospital, we would put like one of those tents or a cool mist tent on them. So they're breathing this air that's moist, that can, moisten up the airway so we can stop that dry cough, right? These kids don't like to get into these tents, right? But there's a hose that connects to the tent. We can take that hose off, have that child sit in the parent's lap, and then they can just put it in their face. And now they're hugging by mom, and we're both inhaling all of this nice, moist air, and the kid's getting what he needs. The kid's happy because anything respiratory, you don't want a kid upset and restless, do you? Not at all. You want them calm. Mommy's lap, no better place than that. And of course, with this, if we can give cough suppressants, usually there's no secretions. Usually it's just a big, bad, dry cough with this thing. Um, they used to use a lot of codeine or hydrocodone type of cough medicines, but I know today it's really hard to get. So there are, all the different other ones, Robitussin, et cetera, that they're going to be using for that. Now, croup. Croup is another common childhood respiratory condition where they'll come in barking. You can hear a kid with croup in the grocery store. I mean, from the other side of the store, they start barking and it sounds like a seal. It really does. Now, croup is an upper airway problem. Why do I say this? Well, the upper airway is the trachea and the larynx get swollen. So think about if this is swollen, can I get air in easily? No. So you have a lot of inspiratory stridor. Important concept. It can't go in. Inspiratory is going to be to try to get it in. Okay. And then that bark, bark, bark to get it out because it's swollen there. Okay. So croup is also known as a laryngeotracheal bronchitis. Okay. So usually about children less than 5 that we hear all of this barking going on. Okay. It's usually happens after a respiratory infection because there's already that irritation that's been there. Again, inspiratory problems. And because you can't pull air in, you're going to see that retractions, right? That barking cough. And if we let it go on, now, this is a little viral something. It's nothing that antibiotics or whatnot that we need. We need to give 1 dose of a steroid or 2 doses of a steroid, POIM. I mean, it is very easy to treat, but if we don't, that swelling gets more, they can't get air in, and it could lead to respiratory failure. Another thing that can happen is that swelling progresses in that croup, the laryngeal bronchitis. Now that epiglottis says swells up. What is the epiglottitis? What is an epiglottis? Well, an epiglottis is that leaf-like structure that covers the trachea. And when you swallow food or a liquid, it covers the trachea so that you don't choke. So food goes down the esophagus. Well, can you imagine if that epiglottis swells up and covers the trachea? How are you going to breathe in? Think about it. You can't. It's covered. Now, how do these children present into the ER? You're going to see them usually, they can't breathe. Many times they're either carried or in a wheelchair. They're bent over like tripod position, like an older patient with COPD, that tripod, trying to find a place where that air can go into that trachea where the epiglottis is not completely covering my airway, okay? They can't swallow, so they're drooling. It's all swollen, so like this, you can't even understand it. That's the way they talk. So can you imagine it? They're drooling, they can't talk, they're bent over, they are restless, they can't breathe. Now, what is our biggest priority on this patient? It's airway, right? How are you going to maintain an airway? Tracheostomy or intubate. And both those trays, it's your responsibility to have at the bedside. Because if we need to intubate now, we need it now. We don't have to wait 2 minutes. 2 minutes could put that child in brain dead. So we need it at the bedside now. That's epiglottitis. So how do we treat all this stuff now? Well, epiglottitis, maintain the airway. You're not giving anything oral to any patient who can't breathe. Adult children don't matter. You just won't. So that would be an IV person. that nebulized mist, like I told you, probably going to be sitting on mommy's lap giving it, but at least they're getting what they need. And we treat epiglottitis with epinephrine, steroids. And that's how we get the swelling down and get that child breathing again. So this is the RSV. It's also known as bronchiolitis. You need to know, like epiglottitis, laryngeal tracheal bronchitis. You need to know what those names are, okay? They'll see them put together a lot. So RSV is bronchiolitis. This is the most concern is your infants. As I said, winter to early spring, they get this preventative immunization, and this is the name. Synagis or palivizumab. You need to know that name. You're going to see that again and again. Hesse, NCLEX, they like that name. So this is one of the ones you need to know. So tonsillectomies or TNAs, tonsils and adenoids, most common with kids, right? Biggest surgery that they have. So most of these children postoperatively are put in for the hospital for the surgery and then are recovered and sent home. So we need to teach our children and parents how to take care of themselves. So what are we going to do? Well, postoperatively, they cannot eat any highly seasoned food. You know, it will burn the area. If you think about what a tonsil and adenoidectomy surgery, what they do, you'll understand. They take a scalpel and cut the tonsils and adenoids out. Then they cauterize those areas that are bleeding, and you're left with these big scabs in the back of your throat. So you're going to have a little smell coming out of there. Shouldn't be horrible, but you will smell it. And those scabs can break off and you can bleed profusely, okay? And I've seen profuse before. So we're going to teach these parents no spicy foods, no gargling, no none of that sort of stuff, okay? No coughing, nothing, no straws, no nothing in the mouth. Younger kids don't like it, but that ice bag on the neck helps. I actually had tonsils and adenoids done at a really old age. I don't even want to tell you. And that ice bag really, really helps you, okay? Older kids, and this is one thing that you all forget on the exam, chewing gum. Think about going up in an airplane and your ears. Because remember, tonsils are by the ears, right? So those ears can get plugged and clogged, like going up in an airplane. What do you do when you go up in an airplane to help your ears? You either yawn, which you shouldn't do with tonsils, or you chew gum. So chewing the gum relieves the pressure in the ear, but only the older kids can understand that to do it, okay? As I said, you shouldn't have some big odor. You shouldn't have like all of this pain and stuff. So if you do, that you should seek medical attention. There could get an infection, of course. And the other thing is to keep them resting for at least a week, up to 2 weeks. And I'll tell you why that's important because I have another story. 7-year-old girl came to me. I'm triage nurse. Just went to the ENT for the 1 week post-op visit of a tonsil and adenoidectomy. On the way home, she vomited in the car, and it was a big blood. So I brought her directly to the ER, to me, where she proceeded to blow up clots, like liver clots that were coming out of her. She was alert when she came in after she vomited 2 buckets of blood. Nope. So I just picked her up. I carried her into the resus trauma room where we had to resuscitate her with fluids. This 7-year-old girl got 1,000 mLs of normal saline. Her heart rate was 180 when we stuck her on a monitor and got an IV in her. So the point of my story, they can bleed and they can bleed profusely. So to really emphasize that with parents, to have them rest for the first weeks and to follow these instructions. Now, pneumonias, there's all types of pneumonias. There's inhaled, there's aspiration, and then there's just pneumonias where they clog up with fluids, etc. Remember, bacterial pneumonias we'll treat with antibiotics, but there's such a thing as viral pneumonias, okay? And again, how do we treat viral things? Symptomatic, fluids, rest, antipyretics. So aspiration pneumonia could be during feeds, or it could be that powder. I do remember, and this is crazy, I remember baby powder that was in, the stock room in the newborn ICU many years ago. They didn't understand the powder in the air and breathing it in. I mean, we do now. I mean, that's why I put that picture there, because I used to love the smell of Johnson and Johnson baby powder. I think it smells really good. Smells baby to me. So that's one thing we have to worry about. Have you ever gone in and cleaned your bathroom with bleach and chemicals, and then you breathe it in and then you get this cough? You've got a mini aspiration pneumonia because of the chemicals that have gone in there. So with children, you got to be careful with that. And then the other thing, most importantly, I think, is the feeding. Feeding children, burping them well, not overfeeding, sitting them up when they're done. Another thing kids do is put everything in their mouth. What do you think the number one coin, and I've seen at least 10 or 15 of these, at least. What do you think the number one coin was that they like to swallow, put in their mouth and swallow? Is it a penny, a
Pennies.
nickel, a dime, or a quarter?
Pennies.
Go the opposite end. Quarters. They
Oh.
swallow quarters. Yes, that picture is a quarter. That's a kid I had right there. And it sits there. Now, usually they come in, they have pain. They can't swallow, okay? And they're maybe might be drooling a little bit, but they're breathing. As long as an airway is open, they're okay. Now, how do you think we get that penny, no, quarter out of there? Well, most of them will just swallow it, but sometimes they have to go and they have to get it out because it's stuck. It's a quarter. It doesn't want to move down there. My 10-year-old grandson did that last year with a quarter, and he had to have surgery, bronchoscopy, and get it removed. I've not seen that actually. Most of the time, this is what we did in our hospital when we had a coin, and I had never seen it before. So, what they do, they take a Foley catheter, put it down the throat, blow up the balloon below the quarter, have the child sit on the surgeon's lap who pulls out that Foley catheter, and they vomit and the coin pops up at the same time. Do you know what I do to keep that kid from getting scared? I tell him, if I get that quarter first, it's mine. So he's going to pull that out and the quarter's going to fall out. I said, if I get to it first, it's mine. Do you know that kid is not worried about this coming out? He's worried about getting on that floor to get that quarter first. And it changes the whole environment. And I've had parents tell me afterwards, thank you. They didn't even know what had happened. And before they knew it, it was done. And of course, I would never take the quarter. So pertussis. Pertussis is the whooping cough. This used to be eradicated almost completely, but there are some parents that and people that do not believe in immunizations, and that's their right. But if they get pertussis, they can spread it to everybody. Even if you've had the immunization, you always have the chances to get it. Extremely contagious. It is airborne, requires airborne isolation, and they place these children on azithromycin as the treatment for it. Smoke inhalation, this happens a lot, especially during the winter and fireplaces and in Florida, hurricanes trying to cook inside the houses with things and, smoke injury. How do we treat it? 100% O2, 100% O2. That's the way it's treated. Cystic fibrosis. This is going to be heavily hit on your exam, okay? Cystic fibrosis is a respiratory condition, but it's also more than that. It is mucus in the body, the lungs, into the pancreas, small intestines, and it also causes the loss of electrolytes through the skin. All right. So your skin, in fact, infants that have cystic fibrosis, I would tell the parents, lick their skin. I mean, I would say I would lick it, but no, I'm not licking anybody's skin. But when they lick it, it's like highly salt. The salt just perfuses out. This is a child that you would never hold a salt shaker on. You would always give them as much salt as they wanted. Because of all that mucus and the clogging, and they can't expectorate it, you are going to see them coughing. This mucus is like a petri dish that grows bacteria. So they're chronic bacterial infections. They're wheezing. Now, dietary wise, they don't digest fat. They don't have the pancreatic enzyme that digests fat. So they lose their fat vitamins. And if they eat fat, you're going to have foul smelling, greasy stools. So you try to have a low fat diet. Because you can't eat fat, and fat is the highest calorie of all the food groups. I mean, carbohydrates and proteins are 4 grams, 4 calories per gram. Fat is 9 calories. So you can see they're not getting the calories that they need there. So again, you're losing all of this nutrition, and think about fat vitamins are being lost too. So a child, if we didn't know that they were going to have cystic fibrosis, we can do a test. Remember I told you they have salt that oozes through their skin? We do something called a sweat test. And it's just probes that go on, it doesn't hurt, and it just measures the sodium that's on the skin. And it's going to be very elevated. So once we decide they have cystic fibrosis, we know this is a multi-plan that we've got to do. Antibiotics are going to be used to treat those chest infections, whether that's in an aerosol. I've seen tobramycin, gentamicin aerosols, very common to be done. Also, they're going to get PICC lines, and they're going to have IV antibiotics chronically at home because, oral usually doesn't take care of it because they're so strong, these infections. They're going to get all sorts of respiratory treatments to thin and to be able to expectorate all of this mucus in there. They are going to get an aerosol, open the airways, and then give aggressive chest physical therapy. That has to be done before they eat. This is done 2, 3, 4 times a day, depending on the severity of the cystic fibrosis. Minimum morning and night, minimum right there. So now that we've gotten the lungs open and we can eat, we've got to do something before we can eat. Because we don't have the what it needs to digest fat, we need to give a something called like a pancreatase. It's one of the names, where this replaces the enzyme that the pancreas cannot produce. And it helps in the digestion of fat. It doesn't completely take care of it, but at least we're getting some of the fat. Now, instructions on how to give the medicine. Sometimes they've got capsules with little beads. Sometimes they're enteric. You never, ever crush those things. You can open the capsule and put it on the food. It's not like you have to have it before you eat. It's with you eating. This is okay here. There are ones type of meds that are powder. Now, just like some of the other respiratory stuff in the adult world, we have to rinse your mouth when you're done. Same thing here. Protect the teeth is what we're doing. And the one thing I think we forget most of all is to adjust the dosage as we grow. Children 1 year may gain 2 pounds. So you really don't need an adjustment. And then all of a sudden they gain 10 pounds. Now, that's when they need that increase in dose. And usually we're delayed. I see that a lot actually in seizure children, where we haven't increased the dose and they have a breakthrough seizure. So respiratory management, everything to keep those lungs clear. Bronchodilator medicines. Physical activity is important, not PRN. It needs to be done 2, 3 times a day. And swimming is an incredible exercise. Hold your breath, go underwater. It helps your lungs pop and keep open, doesn't it? We're going to do that aggressive therapy of any infection in their lungs. That's that nebulized aerosol, the PICC line aerosols, to get rid of those infections. So feeding these children. We don't get a lot of fat still, it's not being absorbed. We're losing sodium like crazy through the skin. So how do we feed these children? Because remember, cognitive delays are going to be there. They're not going to grow if they're not fed nutrition. So high protein, high calorie, low fat. and keep the salt shaker. In fact, put extra salt on their food. Okay? They have a lot of issues with GI tract stuff, rectal prolapse and reflux. And again, they're just treated symptomatically. All right, that's good enough. Now, cystic fibrosis and pregnancy. It's been asked if women can get pregnant if they have cystic fibrosis. Absolutely. They don't usually have a problem with it, but they're going to be extremely high risk. Okay. Men who want to get their woman pregnant and have a child, if they have cystic fibrosis, they can't. And the reason is their vas deferens is filled with mucus and the sperm can't get to the woman. They say pregnancy is possible for men 1 year after bilateral lung transplant. And many men do it just for their woman, just to be able to have a child. Can you imagine? Sleep apnea is just the same thing as adults. These are kids who snore. What do? Well, we're going to try to give them, tonsils and adenoids and whatnot. But some of them are so bad they got to be placed on these CPAP things. Okay. Same thing. We do the sleep study like we would adults. If there's something in the airway, we'll take care of it. And remember, children need to sleep, so we're not going to be alert and aware for the day. Now, acute respiratory distress syndrome. This is when the lungs get really hurt somehow. Think about drowning. Think about drug overdose, aspiration, and not breathing type things. Sepsis, attacks everything. And trauma, ran over by a car. And I've seen all of them, right? The thing with respiratory things, for instance, you can have a kid drowning in a pool, was underneath, was out. They brought him up out. They revived him. By the time rescue comes, the kid is running around and alert. Like, oh, the kid's fine. No. It can be up to 3 days later that kid's going to show symptoms of respiratory depression and a respiratory arrest eventually, like pretty quickly. So these children are all admitted to a unit where they can at least be on a step down, ICU, O2 monitor to be monitoring that. This is one of the things that we treat ARDS with, and that is, your ECMO. I actually got certified in ECMO, and it basically pulls blood off, oxygenates it, and puts it back in. It doesn't support the heart. That is for open heart surgery, CPS. This is only lungs, ECMO, and that's all it does. And this, what it does, it works for the lungs, and we could take care of the lungs and let them rest. And it's what we're doing. CPR, I know you wanted one on the last exam before it. This CPR is just telling you that even though CPR is done in a hospital, years ago, we wouldn't let parents anywhere near it. And then children, adults would die, and they weren't there to hold their hand when that person left, right? And what it was felt was, it's better to have that person there, as long as somebody's there supporting them, whether a supervisor, a social worker, or the charge nurse, whoever, somebody support them. So again, remembering the family when things happen. Asthma. Now, this is lower airway. So croup is upper airway. Epiglottitis, I can't get air in. Inspiratory stridor. Asthma is an inflammation of the lungs, so air comes in because up here is all fine. Oral airway's fine. Air gets in and it's stuck. No, I can't get it out. Prolong to try to get the air out. Expiratory wheezing. So how do we manage this? Well, first we got to diagnose it. We'll do all the PFTs and skin testings and all of those things. And in children, in any disease that they have, our goal is always to maintain normal activities, not a problem. Drugs that we use? Well, we're going to be using long-term medications for them. They're going to be getting that drug for that prevention of bronchospasms that we use morning and night. In children, it's something called Pulmicort, and it's got a little bit of steroids in there. And that steroids is going to prevent, all of these bronchospasms from going on, right? So morning and night, we have the rescues that we give. And then during attacks, we're going to do some sort of corticosteroid, steroids. And then cromolyn is another, it's Atrovent, something again to help calm the lungs down. Now, status asthmaticus is scary. And I'll tell you why I know. My husband was in the ICU for 12 days. He started with bad, not breathing well. He has asthma. We took him to the ER. He was admitted. That evening, he was transferred to the ICU in severe bronchospasm. And for 12 days, off and on, he couldn't breathe. Fortunately, he didn't end up intubated because what's one of the biggest things we know about respiratory and what we can do if we know nothing? Well, if you have a patient in respiratory distress, the first thing you have to do, calm them down, right? Talk them down. That's what I did with my husband, and it worked. So put that child on the mother's lap. Put them somewhere where they're comfortable because they're going to breathe easier. They're going to be less anxious, and you're going to have better chances of bringing them back. All right, let's go to our cahoots. Who wants to win respiratory? We have been joined by Professor Morris's class. She's not feeling well, so they're here for the last half of the lecture, okay? We're going to be starting with a cahoots that goes on for the pulmonary, and then we are going to finish the cardiac and a cardiac cahoots. And yes, you will get the recording. I think if we look at both respiratory, cardiac, they're both scary areas and subjects. I think respiratory is harder cut on your exam, always more harder touched on it than cardiac. Cardiac, there's a couple things with it, but it's mostly all about your respiratory. Now, I don't look at these scores, guys, as I said, for the other class. I don't look at who did what, who got what wrong. That's not the purpose of these cahoots. The purpose of this cahoots is for you to get information and to be immediately tested on concepts you have to know. So that's what these are for. It's not for me to score you. No. Pediatric respiratory system. 30 questions. A majority of upper respiratory infections are caused by what? So most upper respiratory infections are viral, okay? I mean, that's why you go to the doctor's office and they say, oh, just treat them symptomatically. Antipyretics, fluids, and rest, right? And then they're not putting you on antibiotics until we can figure out it really is a bacteria. You walk into a 6-year-old child's room and you find them not breathing and doesn't wake up. What are you going to do? So when you walk into a room, you are a one-man CPR, and immediately the first thing is doing the chest. They used to say administer two breaths and then start chest. Do you know what happened with that? People wouldn't give the breaths and then wouldn't do the chest compressions, and people were dying like on the street and whatnot because they didn't want to put their lips on somebody else. But they found that just doing chest compressions, there was enough oxygen in the body that could support it for enough time for somebody else to come and help. That's the reason. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? What do they look like? Besides sitting in the corner and sucking their thumb because they don't feel well, right? So children are a little bit of everything. You're going to see them a fever. You're going to see they're not going to eat. They might even vomit with the mucus they're getting, and because of that, they might have abdominal pain. Again, anytime fever, respiratory, anything in children, your goal is to have them feel a little bit better. And as long as they're not vomiting too much, get that fever down. I mean, suppositories are there for that reason. And once the fever's down, those kids feel better, will start drinking, and can help you get them better. A multi. What do you look for when assessing respiratory function? I do a lot of my assessments just by looking. I don't necessarily have to touch or listen. You can see a lot with your eyes. And if you're a nurse who worked in the ER as many years as I did, you have to when you've got so many patients you're seeing. It's just like, oh, yeah, I got to go that one first. So you see how quick they're breathing. Is it labored? How deep? How shallow? And is it easy? Or are they struggling? All of those things are telling you, are they okay or are they in trouble? What would you look for after a child has a tonsillectomy? So remember, they cut those things out of the side of your throat, they cauterize them. And what are you going to be watching for? What's our concern? The thing and we're most concerned about with these children post tonsillectomy is that there's bleeding. I was telling my class a story about one girl who came in and just 7 days post tonsillectomy had been seen at the ENT, just vomited clots of blood out of her, required going back to the surgery and getting recauterized. I mean, that's how serious it is. Swallowing is going to be telling me she's bleeding, and that will make me look so that I can do an intervention before it becomes dangerous. Multi. Nursing care for a child status post tonsillectomy include, remember, you want these guys side lying, right? So if they bleed or they ooze, they can ooze out of the side of their mouth. Put it back, they might aspirate and choke when they're still under quite anesthesia drugs. So again, pain medicine for sure, because we still want them to drink fluids. Remember, fluids should be more of not red stuff. Jellos, not red stuff. Okay, popsicles, not red stuff, because you want to be able to see if they're bleeding. Spicy foods, we don't want them to have, right? For sure, because that'll burn that area. Gum is used for older kids because it helps with their ears. And then that ice bag. Young kids won't put it on, but older kids may, and it helps. A multi. What signs and symptoms would you see in a child with otitis media? Infection of the middle ear. Now, this is the one misnomer. Everybody thinks that otitis media is fevers. I've had multiple tubes, multiple ear surgeries. I never had a fever with it. Usually, children, they don't have it in there. So, Ear pain, for sure. And they're going to point which ear. Sometimes that inner ear does burst, and then you'll see oozy stuff coming out, yellow and serous looking. And of course, kids who don't feel well, in pain, are not going to eat. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Dry, bothersome cough. It is bronchitis, and the other name for bronchitis is tracheobronchitis. You need to know those. Epiglottitis is laryngotracheobronchitis. Bronchitis is just tracheobronchitis. You need to know the difference in those names. Asthma is not a dry, bothersome cough. Yes, you cough, but it's more of this expiratory wheezing that's going on and this coughing, 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 different than bronchitis. The monthly immunization for RSV. So Synagist, palivizumab, is a biologic, is what we use for RSV. It's actually sort of similar to what we use for, with COVID. It's one of those biologic things that we do. Hib is one of the injections that we give infants 2, 4, 6 months. Humira is used for, let's say, rheumatoid arthritis. Oh, we're not to Indocin yet. That's next into the cardiac. A 4-year-old child's been taking meds for asthma, but they're still wheezing. What information is important to ask? They're taking their meds, but they're wheezing. Why? So a lot of it sometimes is just that they don't know how to push the button down, inhale at the same time. I mean, I've even taken adults and given them a spacer, and they have all sizes. Mask fits around the face. There's a tube. You put it in the side, and then you keep it compressed. Push it once, twice, whatever the dose is. Let them breathe it out a couple times, and now they got the whole dose. What I would do with asthma kids coming in with asthma, and they're still wheezing, I would ask them, show me how you give yourself your rescue. Doctors don't do that. An 8-month-old group exhibits what signs and symptoms of respiratory distress? So here we are, 8-month-old respiratory distress. Which one is it? Sort of have to know what an 8-month-old vital signs are, don't you? So respiratory rate of 25 and 108, that's normal for that child. Any O2 sat above 92 is normal on your children. Abdominal breathing pulse of 100 is absolutely normal. Respiratory distress, retractions, restlessness. Good. Signs and symptoms of asthma include all except they're gonna have that cough. The cough. It's like all of a sudden they start coughing and they can't stop and they can't breathe and they can't catch their breath. Okay. And you can hear them, the wheezing. There is a prolonged expiratory phase. Think about it. Air gets in, or always fine. It gets down to the bottom of the lungs and it gets stuck because now there's swelling and it can't go out. So you have to push. So it's prolonged expiratory. What should you not do to children diagnosed with croup and epiglottitis? So anything where there's swelling in the oral pharyngeal airway, you don't go in there and examine, put anything in there, straws to drink, nothing in the mouth. Just make more swelling. Nursing interventions with a patient with epiglottitis would include you have a kid who can't breathe, is leaning over, is drooling, has a garbled voice, severe respiratory distress. What's your major? What's your priority intervention? Well, it's always going to be about airway, right? So, what does the airway? How are you going to get an airway on this patient? There's a big thing covering the trachea. Can I get an ET tube in there? Or I might need a tracheostomy trape too. Something to get an airway. That's your priority to have at the bedside. Which triad suggests epiglottitis? So epiglottitis, you got that epiglottis over the trachea. So it's about the throat, yes. I can't swallow because it's all covered there and it's all drooling. It's perfect. A multi. Treatment for infectious mononucleosis, your kissing disease. So who wants to put them on antibiotics? Epstein-Barr virus is the cause of mono. It's a virus. No antibiotics. How do we treat a viral condition? Rest, fluids, antipyretics. But the biggest thing is protect that abdomen. Do not rupture your spleen like my little boy did. I can't handle it. I'll die. When doing an admission on an infant that has a low-grade fever and a loose cough, what information is important to ask? You're admitting an infant. They have a fever and they have a cough. What do you need to know? I'm doing my admission history, my admission note. So, what an APGAR score is not going to really tell me anything about the child. I need to know their immunization status because I need to know to protect me, or are they going to go in a room with another child? I need to protect that other child. Highest fever, yes, I want to know what's been going on, and I need to know the medications because I'm going to have to give antipyretics of some sort or something else. How is cystic fibrosis identified? So cystic fibrosis today, we've got all those pregnancy tests that we do, and they'll be testing mommy and daddy and what looking for the gene. But sometimes that isn't done. So then the baby is born. Children with cystic fibrosis at birth will not have a bowel movement or their meconium stool like normal. Usually at birth, they're having their stool, right? It could be 2 to 3 days later. At up to 2 days, they're going, uh-oh, no stool. They're going to test for cystic fibrosis. One of the symptoms of cystic fibrosis in a brand new newborn is constipation or no stools. And what will they do? They'll be doing a sweat test and they'll be checking to see if they have cystic fibrosis. How are they going to treat it? You're going to treat the lungs and they're going to give stuff for the diet, also some of the enzyme, okay? A multi. What is included in the plan of care with a child with cystic fibrosis? So cystic fibrosis is actually three components. It's the lungs, it is the food, nutrition because of the pancreas. It's also the loss of electrolytes through the skin. So we need to do aggressive physiotherapy. Give the aerosol, do chest CPT before meals. When we eat our meals, high protein, high carbohydrates, low fat. And we're going to be giving those pancreatic enzymes, however they're giving them through capsules or powder or whatever it is, with the meals. We're going to be giving it. Also, this kid is losing sodium salt through his skin. It'll be a regular or high sodium diet. We need to replace that. They're losing electrolytes. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? What are your key clues here that's telling you something? We've got a heart rate of 88 and we have vomiting. Heart rate of 88 and vomiting tells me ditch toxicity, doesn't it? And with infants, one of the only things they may show you is that they're vomiting. You know, that nausea, that retching, and that vomiting it might be it. Heart rate might be a little low, but the vomiting, I would never give a child digoxin that's vomiting. I would call the doctor, get a dig level being done, unless it's already been done, and do it before I give the digoxin. Better safe than sorry with digoxin. Which information is most important when rheumatic fever is suggested? Now, I put this here, but it's sort of a cardiac problem, but rheumatic fever symptoms aren't. So that's why I put it here and there. So rheumatic fever starts with a strep throat, strep that's been not treated or not completely treated. And that strep infection starts with the body, and you're going to get nodules and you're going to get rashes. And of course, it's that sore throat and whatnot. But the one thing that happens is it attacks the mitral valve. The mitral valve, once it's attacked and damaged, will always be damaged. I mean, in rheumatic fever, there's even this weird chorea movements that they can't control movements. Everything can be reversed. But with rheumatic fever, due to a strep infection, the one thing that cannot be reversed is the cardiac valve. The mitral valve cannot be repaired. It must be treated medically or surgically. Signs of shock in children include all of the following except. What do you know about shock? What do you see? So, shock, elevated heart rate, decreased blood pressure, decreased urine output, prolonged capillary refill. Do you see all these things? Altered mental status, they're becoming no blood's going to the brain. So, hypertension, no, you wouldn't see that. In fact, you want to get that blood pressure up. Which of the following is the most common of shock in infants and children? Infection. Infants and younger children, they don't have the defense to fight, okay? So once it gets there, and if it's not treated, this child will go into a shock. Infection, they can't handle it. A multi. Signs and symptoms of rheumatic fever. I'm going to go over it again in the next chapter. I just wanted to introduce you because it is a sore throat, right? It's all the above. They get in, of course, they have the sore throat, so respiratory is going to get involved. Chorea is that movement where they can't control themselves. And then the joints get swollen, those subcutaneous nodules and rash, all of those things. Again, remember, all of that go away with long-term antibiotic therapy. The only thing that won't be solved is if the mitral valve has been damaged. A child has just had abdominal surgery and can't cough well enough to expectorate secretions. What's your priority? They gotta cough that secretions. They're gonna end up with pulmonary complications, aren't they? What are you gonna do? Well, if I can't cough well enough, I just had abdominal surgery. You're not going to want to take a deep breath and cough because that hurts, right? So medicate them with pain. Then you can reposition them, get them out of bed, send them spirometry, get them ambulating, all of that stuff. But don't do it before you medicate them with pain because then they can do it more effectively. That's the point of this. If they can't cough, they can't do something, and they've had surgery, make sure they're comfortable before you make them try. Medicate them for pain. An infant of 3 months has a fever of 103.6. What are you going to medicate that infant with? For the first 6 months of life, it's only acetaminophen. At 6 months old, you can add in ibuprofen. Okay? Why? Ibuprofen is an NSAID. It has something to do with bleeding and platelet coagulopathy. So they don't introduce ibuprofen until they're 6 months old. Okay? I put that there for a reason. A multi. A critically ill child is placed on complete bed rest. What can you do to prevent complications? Child's critically ill. They're on bed rest. What are you worried about? Bed rest, critically ill. Little bit of everything. Now, are we going to keep the head of the bed flat? Probably not. I mean, you want to do something for the airway. The only way it would be flat is if the doctor ordered that because of the condition of some sort. But let's keep the lungs going on. Let's turn them every 2 hours, lotion the areas, rub them up, make sure there's nothing going on. They get foot drop, they get all the things that adults get. Children can get those complications. Keep them dry and then use pillows, blankets. I use beanie babies for ET tubes and stuffy animals for them to hug between their legs, and then blankets and pillows behind their back and get them all snugged up. And the parents come in with all these little toys and stuff around them and go, oh my God, they look so comfortable. Plus, the kid with their eyes are open, they're seeing these cute little animals, not all of this bing and bang and bottles of IV fluids and stuff. So it's a better environment. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? And it is an oxyhood. Now, I see some of you did nasal cannula. Let me give you a little visual. You take a tube, put those two things up the nose, attach it here, and infants, you got to tape it on them because it'll come off. You don't put them behind the ears, up under their neck. You don't do that on children. They'll choke on that. So you tape it. They don't like that at all. Blow by tickles them, and they're like this all the time. And it's not accurate. You don't know how much you're given. Okay. And then the tracheal, oh my God, I've been intubated. It's not fun. They don't want that. This oxyhood is a clear plastic thing. They can suck on the pacifier their fingers and they can move their head around and nothing's tickling them. And it is extremely accurate. Okay? Oxyhood. It's a wonderful thing. A multi. What procedures are used to keep the lungs open with a child with cystic fibrosis? We don't want to ambulate PRN. We want to ambulate BID, TID. It's not going to be a choice. They need to ambulate, right? Because you keep the lungs open and moving and exercising them. And last question for respiratory. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? What do they need to know? A little bit of everything, right? Take them right before the meals. I mean, if it has to be sprinkled on the food, fine, if that's the way they have to take it, but it's right before and with the meals. You can sprinkle it there. If it's powder, you must rinse. And the one thing I think everybody forgets to check, and you didn't hear, which is great, is that increase the dose as the child gets older and bigger. They need more. All right, let's see how this one did. And number three, Dionysi, yes. Number two, Nick. Okay, Nick. Number one, drum roll, AG, and Raya and MM. Good job, guys. All right, we're going to go back to the PowerPoint. And we're going to go do the cardiac system now. And I know most of you are like, ooh, the cardiac scares the heck out of me, right? Am I wrong? All right, cardiac. I've got a couple pictures here. Remember the hearts in children, most of the things that we're going to be talking about are congenital heart defects that babies are just born with them, okay? Most of them. The other part of them is something that happens. Usually, the big thing that is happens is like a viral infection, and it causes viral cardiomyopathies. The heart gets big and stretched, and they don't work really well. I mean, just think lupus, autoimmune could attack the heart too. So, but most we're going to talk about congenital. So, this is a picture from your book. I put it here because most of you need a refresher on how blood goes through the heart. So I'm going to mention it, and you need to know what's on the right side and what's on the left side. So you need to think about this. So let's come about how the heart gets the blood in after a beat. So it comes up after a beat, up the inferior superior vena cava, goes into the right atrium. It goes through the tricuspid valve into the right ventricle. It goes up the pulmonary valve into the lungs. It goes down into the left atrium by the pulmonary. There's actually four veins, which I didn't know that. I always thought there was one. And then it goes through the mitral valve. That's what I was talking about with rheumatic fever. The mitral valve goes into the left ventricle, through the aorta, up the aortic arch, and to the body. Okay, let me give you your first cardiac condition, and you need to know this. So just think about the concepts involved with this. So think about your heart vessels as a big garden hose. That hose that came off the heart, up the three little things that go up to the upper extremities, and the aortic arch comes down, and let's say there's a kink or a narrowing in that hose. Blood can't go down anymore, can it? So what are you going to see? Decreased pulses or no pulses, pedal, popliteal, femoral, don't matter. There's not going to be any pulses, right? And your blood pressures are going to be lower because less blood flows there in the lower extremities. but then all the blood is going backwards. So the upper extremities have a higher blood pressure. It's not going down, so it has to go up. Now, because that blood can't go down, and now you've diagnosed it with no pulses, and you've got lower extremity blood pressures are lower, and the higher extremities are higher. Now you're going to start listening to the lungs because that blood's going to go back up around into the left ventricle, up to the left atrium, and back into the lungs and fill it up, and you're going to go into congestive failure. That is called a coarctation of the aorta. Very, very common symptoms that you see with this condition is exactly what you see with most congenital heart defects. Now, that story I just told you, of course, I had a 3-month-old little girl, and they couldn't diagnose her on the west coast of Florida. So finally, they brought her over to our hospital, and she was diagnosed coarctation aorta. Now, what were her symptoms? Poor feeding, tachypnea, tachycardia, failure to thrive, activity intolerance. She was delayed. There wasn't any history at all, but she wasn't doing good. All right. Cognitively, she wasn't there and she wasn't gaining the weight. Something's going on. What is it? I think with congenital heart defects, especially those that don't get completely oxygenated, this is your nursing diagnosis. Inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. If I don't have energy, I'm not going to suck and swallow and eat because I can't. I can't do it. So, looking at these children, you're going to see different things. This child was actually, the coarctation is fully oxygenated. But what if a kid had something else? And we're going to go into those in a second. But their O2 saturations, not all children, all people have O2 sats above 95%. There are children born that we're going to keep their O2 sats. Oh, above 60 would be nice on some of them, believe it or not. And that's where they need to be. We don't need to give them more oxygen. They need to be at a 60. We're going to go into that in a second. So we're going to look at their color. We're going to look at their chest. Are we going to see any murmurs? I like to touch the chest. Sometimes you can feel murmurs just by vibrations on newborns, okay? You're going to palpate the abdomen, pulses. Let's look at the heart rate. What is the heart rate? What's the blood pressure? What's the heart sounds? Are there murmurs? What's going on? So once these children, are admitted and we know something's going to go on, and we're going to be, first of all, doing an echocardiogram. And this echocardiogram is just like the ultrasound we do for pregnancy, but we're looking at a heart and we're looking at the way blood's flowing in there. And if we find something on that echo, definitely that child is going to be going for a cardiac catheterization. There's 2 types of cardiac catheterization. One is to fix stuff. That's the electrophysiology studies. That's to fix some stuff. And the other stuff is just basically diagnostic. One second. I had to coordinate getting my grandson here today. Sorry, Daddy called. I get my Christian with me. I love my Christian. I talk all about him. So he's coming to Nana house. Nana time. Okay. So cardiac cath, you need to know what to do, right? So when we're going to give a cardiac cath, it's like sending them to surgery because they're going to knock them out. They're going to do things. They're going to stick 2 big catheters in their right femoral artery and right femoral vein. Okay. And they're going to inject dye into the heart, and we're going to see the way the blood is. Is there any holes? Where does it go? Et cetera, et cetera. Once the catheterization is over, they pull out these catheters and apply big pressure to where those big IVs were. They don't leave anything there. They take them out. They have to put a big pressure dressing on there. Some older kids, they'll put a big 5-pound weight on there to hold it, because if you can think, these artery and vein, they're as big as my finger on a newborn, and blood can squirt everywhere quick. So let's keep that pressure up. So when that child comes back, you can see where I'm going with this. Number one, check the dressing on the groin, making sure there's no hematoma, there's no bleeding, because that's your priority. That kid can bleed out in a minute. Then you'll do all the other stuff, vital signs. We're going to look at the pulses. Now, that right leg could have a decreased pulse than the left, because of the putting those catheters in could cause some inflammation. Just document it. Tell the next nurse so that they know what's going on. It's normal, normal, normal. Postoperatively, you need to keep that right leg straight. You can't bend it. They cannot get out of bed for 24 hours. We don't want those clots that were on those 2 catheter sites to pop off and to bleed. So you do the vital signs, you're going to check the dressings, either IV or PO is fine, and then blood glucose levels. Why do we do those? Well, I know most of these cardiac casts are those newborn kids that have congenital defects, and they are really sensitive to their glucose. Did they get enough glucose in the cardiac cath lab, or didn't they get any? They're fed up to 2 hours prior to procedure. So do they have enough glucose in them? And their glucoses go down really quick. So we check it just to be sure. And again, the biggest risk is from those catheters. So congenital heart defects. Most common abnormality is a VSD. And what type of children have the most of those? Down's children. Remember, Downs. These are the kids that have these crazy type of diagnosis. AV canal, truncus, VSD are the big 3 that they have. You don't have to know them. They're just defects in the way the heart was shaped, okay? So knowing that Down's kids are, again, VSD is a big one. As I said, some of these diagnoses, some of these children, like coarctation is a acyanotic. They have a perfect O2 saturations, but there's other ones that are cyanotic. That means periodically they go less than they should be, or sometimes they're constantly on a lower O2 sat. I've already mentioned it to you. Now, there's something called shunting in the heart. So when I explain the heart and the blood flow, the right side is a lot, really low pressure. That heartbeat just gets the blood in there. So it's just getting around to where it needs to be. So the right side of the heart is low pressure. Think about the left side. 4 pulmonary veins flowing blood into that left side. That left ventricle is pumping like a crazy person, getting the blood around, right? That left side is full of pressure. So look at that picture. Remember they're born with that patent foramen ovale at birth? It's part of that fetal circulation stuff. You're going to see sometimes there might be a hole in that upper chamber called an atrial. The septum is a hole, so atrial septal defect, ASD. The blood is going to go from the left side and shunt to the right side and go back up to the lungs and around. So there's questions that say, if you have an ASD, a VSD, PDA, what's going to happen? You're going to keep reoxygenating blood. I'm going to go to the PDA in a second. But you have put oxygenated blood back to the unoxygenated side, back into the lungs, and that's shunting. So cyanotic diseases. This is in your book again that you can look at. Increased pulmonary blood flow. I just told you about ASD and VSD, right? Left side flowing over to the right side, back into the lungs, increased pulmonary blood flow. PDA, I'll go into that in a second. Just think about a PDA that's fetal circulation. This is what I call an oxygen giver, when oxygen can't come from anywhere else. And the heart's blocked off and it's not doing it by himself. So this is the oxygen giver. Obstruction, I already talked about that coarctation of the aorta. It kinks the hose and blood goes back into the left side, up to the lungs, fills it up. Heart failure is what you're going to see if it continues for a while. Now, There's two terms, stenosis and atresia. Stenosis is a narrowing. It means that you have a big vessel, but it's not as big as it could. But there's still blood flowing. It's narrowed. Atresia, A, means without. That means there's no connection. If we looked at decreased pulmonary blood flow, you see tricuspid atresia below that. That means that right ventricle and that right atrium, there's no valve that connects them. Gee, what about oxygenation on that patient, right? It's not going, nothing's going to the lungs. So again, atresia, we'll get there for you. And then the other one that we talk about a lot is transposition of the great arteries. And it's cyanotic because the aorta and the pulmonary artery are switched. They're transposed. How do you think we fix that? We pick it up, turn around, and set it back on. It's exactly that. It's exactly what they do. It's called an arterial switch operation. It's quite intense. Okay. Now, cyanotic, transposition, there's no oxygen. Tricuspid atresia, no oxygen. How am I going to get this baby oxygen so they can live? I'm going to keep the fetal circulation or that patent ductus arteriosus open. And what is that thing? It connects the lungs, pulmonary artery, oxygen, and it connects it directly to the aorta, up systemic to the body. And now we keep that going until surgery can be done. And it's done so successfully. In fact, these transposition kids and tricuspid kids, you don't have to do the surgery right away once they're getting oxygen, okay? They are given bottles to feed. If they're full-term infants and no other problems, they're fine. And then we do surgery on them a week later. It's not a rush. So how do you know now that transposition that you have said, oh, we need that oxygen giver open because that's the only way they're going to get oxygen? How do we know it's open? How do we know that PDA is still there? Because at birth, this closes without mommy. It needs mommy's prostaglandins, this hormone she produces, to keep that duct open. Well, mommy's gone. Well, we can give them a slow, continuous, synthetic prostaglandins that works just beautifully. And it will keep that thing open until we stop it and we don't need it anymore. How am I going to know it? Well, the drip is going. Does that tell me? No. I need physical. I want an assessment. Listen to their chest. This is the loud washer machine murmur. You hear, it just sounds like it's a washer machine. It's that evident. The other thing is, most of these kids are cardiac. So most of them have all these central lines, arterial lines, and all of that in. Well, the arterial line, normal blood pressure on a newborn is 60/40. Normal, systolic, diastolic. On a child with a PDA that's still open, or one that we have kept open because we need it, the diastolic is going to be not 40. I've seen 18. Okay? Now, what if we needed that PDA closed we didn't need it? And the body, I don't know, kept it open. It got prostaglandins from somewhere. Well, how do we know it's going away? Well, our blood pressure is going to go back to normal, and I'm not going to hear a murmur. It's as easy as that. So PDA is kept open with the prostaglandins. It is a continuous infusion, and it maintains cardiac output, and it maintains the O2 saturation levels. Now, again, when that PDA isn't needed, and we can close it, if it doesn't close it by itself, we can give something called indomethacin. You need to know these names. Prostaglandins, indomethacin. Don't mix them up. Prostaglandins is a hormone. It keeps that oxygen giver, that PDA open. Indomethacin is actually an IV NSAID of all things. The first time I use it, I'm like, isn't that the stuff we use like ibuprofen? And it is, but it's something that in the IV form can be used very successfully in closing that duct. And again, as we're giving these 3 doses intravenously, they're like giving a dose, like an antibiotic over half hour and the next one. And as we're giving it, we're listening to the murmur. We're watching that blood pressure get back to normal. Again, blood pressures and murmurs are things we're listening to. So there's a couple things here that show you about blood flow, obstructive flow, just showing you different pathways. I've gone over basically what you need to know with them if you understand the flow right side to left side, okay? But there's pictures there to show you too. Now, biggest thing that we are concerned about, we talked about that coarctation girl, right? She ended up in heart failure, which is congestive heart failure. So now not only she's coarctation, I've got to take care of her because she's in heart failure. Now, how am I going to do that? Well, take an x-ray. We're going to confirm it. It's going to show all this fluffy stuff in there. We're also, we'll weigh this child. These kids have usually a sudden weight gain. All of a sudden when the fluid, in their heart starts really failing. So what do we want to do for these kids? They got all this fluid, with the condition. How are we going to make these kids, do the best they can? Well, we want their hearts to function the best we can. The coarctation, we need to fix it or put on medicines that help it. When you're in failure, you're congestive. It means you're fluids. Let's get rid of it. So actually furosemide, most common, Bumix, 2 most common type of diuretics that they use on these children. Because what does that do? Well, get rid of that fluid. The heart doesn't have to beat against all of that extra pressure. So the heart feels better and you got more area where oxygen can exchange. So you get better tissue oxygenation. A lot of these kids, because of this heart, might be placed on digoxin. Remember that vomiting may be the only sign you see in dig toxicity. In adults, they're going to tell you there's yellow spots. I'm sorry, infants can't tell you I see yellow spots, but they can show you vomiting. That they can show you. And we give digoxin just like adults. Count the apical for a minute. Check the electrolytes. Potassium has to be normal. Check the dig level. It's the same values. Okay. Now, hypoxemia in kids, especially with these cyanotic heart diseases, this is one thing that happens with them. Now, when we look at the clubbing is later on in life, and those are some congenital hearts that's still going to have lower O2 sats for life. You're going to see those clubbing maybe at 8, 9 years old, usually not before that. It's not old enough yet. But the one thing that happens to these children, if you think about these kids, they don't have oxygen. What does the body want to do? It wants to be oxygenated, right? So it says, let me produce more red blood cells. So it produces more red blood cells. And now you have a hemoglobin of 18 instead of 14 because the body's trying really hard to produce, somewhere where oxygen that can get to you, okay? So that's polycythemia. Cardiac families are usually generally a pretty neat group. Usually really want to understand and know, and usually the sweetest people. Just again, educate, because they're going to go home with these kids. Some of them are very complex congenital defects, and they have to know signs and symptoms. I'm always talking as I'm taking care of my kids. I'm checking this. I'm looking at this. This is something that could happen. Oh, this is good. He didn't do that. And teaching those parents keeps the kid home where they need to be. I've already gone over that. Bacterial endocarditis. This is something where the endocardium gets an infection and we have to do prophylaxis treatment. Just like adults, kids, same thing. Here's your rheumatic fever, more in depth, like I told you. Again, it's due to a strep infection. A B hemolytic strep infection is the exact term for it. And again, you're going to see all the symptoms, but the big thing that we're worried about is the permanent valve damage. Children can get hypercholesterol. We never checked it before. And we're realizing that we need to be checking cholesterol. We need to be doing EKGs on children younger. They get cardiac dysrhythmias, and we're just checking blood pressures. The kids do have hypertension earlier, and we didn't catch it. So you see how medicine's improving as it's gone along. Cardiac dysrhythmias. Yes, kids can have slow, fast, or irregular heartbeats. I have actually seen the youngest kid with a pacemaker was 18 months old. Pacemaker was about this big, and they had to put it in the abdominal cavity, not up on the chest wall like they would do with an adult. But can you imagine? They'd have to be changing those pacer wires frequently because they grow so quickly, right? Pulmonary artery hypertension is when the lungs get damaged and they close up and say, oh, I'm not doing anything. I'm just going to sit here and protect my alveolar. And oxygen doesn't want to come in, CO2 don't want to go out. And under any exertion, these kids are short of breath, dyspneic, and get that chest pain. I mentioned cardiomyopathy. It's one of the things that I've seen with children. It's that things that happens viral is what I've seen, but just think about it. Lupus can cause problems with the heart too, and a lot of other metabolic and collagen things. Usually, when you have this cardiomyopathy, it gets to the point where you can't tune the heart anymore. It needs a constant tune up. So they end up doing a transplant. What is the largest reason for death? Rejection. Rejection. You can treat an infection. You can't treat rejection. Postoperatively, these kids get a lot of chest tubes. I've seen 4 and 5. And I did work in the adult cardiac ICU, and I worked the night shift. So in the morning, the residents would come in at 6 a.m. and remove all the chest tubes on all their open hearts from the day before. So I got to talk to a lot of adults getting chest tubes out because cardiac ICU in children is mostly newborns because they're mostly congenital. Okay. So they told me it burns and it hurts really bad, but only for a little bit and then it's gone. So I've taken this knowledge back to my kids. So making sure you medicate them for pain before you take that chest tube out. And be honest. Always be honest with kids. Kids don't like you to lie. If it's going to hurt, tell them. But say you'll do everything you can to make you feel the best you can. Okay? That's all they want to hear from you. Because once you tell a kid a lie, they'll never, ever trust you again. As I said, blood pressure is another thing we're checking. Kawasaki disease. This is a condition. It's called acute systemic vascularitis. The vessels, they get inflamed. Our biggest concern is coronary artery aneurysm. Can you imagine an aneurysm of a coronary artery? So these children come in looking like that, whether they're swollen glands. I've seen the worst one that I saw was actually the director of the cardiac ICU's 3-year-old son who came in one night. Of course, I'm the nurse. And he came in with the biggest, reddest, glow in the dark eyes. I didn't know what Kawasaki was when this child came in. I had to learn really quick. Red lips, strawberry tongue. His hands were peeling. His soles of his feet were peeling. This is what you see with it. Now, this is not a bacteria, nothing. This is something where the immune system has done something in the body and we need to correct it. So we give intravenous gamma globulins, IVIG, and we also give high dose aspirin. Today, there are some physicians who give anticoagulants like Coumadin, but in my career, I've seen always aspirin on children. Why do you think they give aspirin to a systemic vascularitis with a possible coronary artery aneurysm? We want to prevent clots. We want to thin the blood. We want to prevent complications. That's why you give aspirin. That was a HESI question about 5 years ago. So, COVID, we all know about it. As I said, look, treatment similar to Kawasaki, IVIG, yes, it's part of it. But we know all about COVID and all of the things that go with it. Shock, we know the big thing is septic shock in children. I've gone over the signs and symptoms of it. Children have, many of them have never gotten medications, an antibiotic before. Remember, one dose can create an anaphylaxis, so always be prepared in kids when you put a dose of something on they've never had before. And we know anaphylaxis, again, get the epi out quick. We've gone over septic shock. Toxic shock is the tampons on the adolescents. Okay, let's see who can answer this question. Surgical closure of the patent ductus arteriosus, my oxygen giver, would result in which of the following? It's the connection between the aorta and the pulmonary artery. You see, we're going to prevent the return of the oxygenated blood back to the body because the PDA is not going to put unoxygenated blood from, no, it is that one. Okay, who wants to win the cardiac cahoots? Anybody? Come on. Let's get some hoorah here. Oh. Okay. And we only have 21 questions for this. And when we're done that, we're going to be going for the day. My class, to let you know, next week I will not be here. Okay? I'm going to my brother's celebration of life. He died on Christmas Eve while I was in Mexico. It was not easy, but they're doing celebration of life. And Professor Morris will be teaching for me. I will be giving her everything you need for that class, okay? I'll be making your quiz. I'll send you recordings. I'll do all the stuff I do. All right, let's get going. Cardiology. Are you scared of cardiology anymore? It's not that bad. It's just the names. So why would a child with tetralogy of Fallot not gain weight at the normal? I mean, tetralogy of Fallot is the most tested of all of your cardiac conditions. The pulmonary arteries closes up and doesn't let blood go to the lungs. And it goes from O2 saturations of 100 to 10. I happened to be one night at 5 in the morning. So congenital hearts, they are going to have all of this extra work of the heart, right? They have no energy because of that. And because they don't have saturations that are normal, it's all that inadequate oxygenation, which leads to decreased energy to feed. And that's why congenital heart defects are always smaller, littler. A clinical manifestation of Kawasaki disease. Korea is rheumatic fever, but the rest are definitely Kawasaki. Which of the following best describes the pathophysiology of Kawasaki disease? What is our big concern here? Not that the eyes get red, not that their lips are blistered and stuff. That's not what we're concerned about. That just tells us go looking, find out what's going on. It is a multi-system vascularitis. So the vessels get all inflamed, microembolisms are going on, and it can infect the coronary arteries, and they're concerned about aneurysms there. In fact, the first thing that my doctor, the head of cardiology, did, get the child in and immediately got the echo machine and went looking for his coronary arteries. I mean, that's how concerning that is. What is the treatment for Kawasaki disease? So Kawasaki, aspirin, IVIG, a multi. Why do you give aspirin to a child with Kawasaki? Why? I mean, we're told not to give aspirin, aren't we? Aspirin, raise disease, all that, right? This is your one thing that I told you, you give aspirin. So, as you know, children with Kawasaki really don't have pain. So it's not that. I mean, it could, but with this, it doesn't. Yes, it's an anti-inflammatory, it's an NSAID. But the big things is prevents clots and it thins the blood. An abnormal hole between the right and left atrium is called what? We have that patent foraminal valley, but it changes in to what? And remember, blood goes from left to the right, and it's called an atrial septal defect. A hole between the two chambers, atrium, between them, there's a septum. The hole is atrial septal defect or ventricular septal defect. What is the treatment for a tet spell? Let's see if you know this. I'll explain it to you. So, in a tet spell, tetralogy of Fallot, that pulmonary artery kinks or it gets covered. It stops, no blood is flowing. There's something to do with the pressure. What we do is this knee to chest because they feel the abdominal cavity, chest cavity. We push it like that. It changes, the pressures and it pops open what's covering that pulmonary artery and brings the blood back. You can do this without a doctor's order. It happened to me one morning at 4 or 5 in the morning where I went into a tet spell. Take the knees, push them to the chest. And my kid didn't come back. We had to get the doctor in there. More than that happened. Multi. Why is prostaglandins given to a child with transposition of the great arteries? So we've gone over Synagis, palivizumab. We have gone over indomethacin. We've gone over prostaglandins. These are things you need to know. So prostaglandins is to oxygen giver, right? So we give oxygen to the body. It's wonderful. It has nothing to do with infections or any of that stuff. It helps with oxygenation because now we've connected oxygen to the body because the switch. It's not happening. And then, of course, it maintains cardiac output because I got oxygen. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? What does indomethacin do? What does prostaglandins do? What does Synagis do? These are things you need to think yourself for the next exam. So indomethacin is given to close it. It's your NSAID. It's going to close it. The prostaglandins is like mommy's. It's a synthetic hormone that keeps that PDA open, okay? When we want to close it, we give indomethacin. Indocin is the other name for it. That's the medical closure. Yeah, you can do surgery, but we would prefer to do a medical closure. Indomethacin. Transposition of the great arteries is what? So the aorta and the pulmonary artery switched, and we're not getting oxygen. And then how does this child live? Through the oxygen giver, PDA. We're putting this patient on prostaglandins and keeping the oxygen going. When measuring blood pressures on four extremities of a child with coarctation of the aorta, what would you expect? You're measuring upper and lower blood pressures. What do you see? So coarctation is a kink in the hose. Blood can't go down, so it's lower in the legs and it's higher in the arms. Good. Early signs of heart failure in infants include so remember, heart failure, filling fluid up in the lungs. These kids are going to get tired out easily. Then you're going to see that poor feeding and sweating. They're working so hard just to suck, swallow, and breathe. Multi. Signs of heart failure in a 3-week-old with congenital heart disease. So, heart failure, they're going to be swollen. They're going to gain weight. That's one of the big things, weight gain. Their blood pressures are going to be, their heart's just working so hard. Their blood pressures, they're lucky they have one. Tachypnea, tachycardic, and probably cool extremities because nothing's going anywhere because their heart's just not working. A multi. Feeding the infant with heart failure. He's got a kid who is already struggling just to, breathe. So now you got to feed them. Their heart is not working good. Their lungs are filling up. What am I going to do? They still need nutrition. So the key with heart failure is small, more frequent meals and increase the calories in the formula, or even in breast milk, we can put breast milk fortifier, which adds calories. And usually it's 20 calories per ounce, any formula. We can go up to 30 if you want. So you can see you can drink a lot less and still get the same calories, right? Then some children, they just don't tolerate it. So they have to be gavaged the rest of it. That sometimes they do the whole feeding like that, but if they can eat orally, it's small, more frequent, increased calories, sit them up afterwards so they can digest well. After a heart transplant, what's the leading reason children die? So I told you we can treat an infection, but rejection just needs a new heart, and that's usually what happens. Nursing care following cardiac catheterization. What are you worried about? So cardiac catheterization, post procedures, number one, please check that dressing because they can bleed out. I had one out of all of them, and I've had too many to know. But that one we did save immediately when they came out because they're jostled down the hall coming back from the cardiac cath lab, and that's when it happens. Remember, post procedure, keep the legs straight, no getting them out of bed. And of course, the little babies, make sure you check their decks. Where is the patent ductus arteriosus? Where's my oxygen giver? Where's my PDA? Oxygen giver. So you need to come from the pulmonary artery. That's where the oxygen is. And what does it connect to the body? Aorta. Excellent. Good job. A multi. What is a sign of digitoxicity in infants? Hmm. Let me think about that one, right? All the drugs that we give adults, we give to children, infants, newborns, but just in a dose appropriate for them. There's no magic drugs. It's all the same stuff. So, digoxin, nausea, vomiting, and that heart rate is low. As I said, how can they tell you that they're seeing yellow spots? They're an infant. That would be the older people. What are the signs and symptoms of heart failure in children? So, heart failure, that means fluid is backing up. The heart's not beating correctly. So, fluid is going to be accumulated. So, daily weights are very important on these children. Intake output, we want to monitor that close, especially with cardiac. Heart palpitations, yes, they're going to feel their heart working. And of course, their hearts are filling up, their lungs are filling up. They're going to be short of breath, dyspneic, tachycardic. Absolutely. What medication is commonly used to relieve the spasms during a TET spell? As I said, sometimes we can do knee to chest. It doesn't work. There's a couple meds we can give. We can give phenylphine, which will blow the blood pressure up quick, but usually we'll give a little bit of morphine. It relaxes them. And then usually these kids in TET spells, we put them on doses of digoxin. So in tetralogy of Fallot, it is not uncommon to have them on digoxin and then see that if they had a TET spell, that we had to give them a little bit of morphine. And we give morphine to brand new neonates. We know what doses are accurate and safe. Last question. Key to preventing post-op complications? And the big thing is get them up, get them moving, deep breathing, coughing. Yes, you're going to give them something for pain, but your whole thing is moving. That moving does help them. I mean, even in neonates, as soon as we can, they're up and out, kids up and out. It just does really help. Karina, number 3. Good job, Karina. Number 2, Dionysia. Oh, I see the name again. Good job. Number 1, an AG. Okay, AG. Good job. I know who you are. Oh, we have a Nick and we have a KW. All right, guys. It was really a pleasure to have the other class in here. You're going to be with our class next week, so I guess it's payback, right? I think we both are excellent professors, so it doesn't matter who you get, me or her. Actually, I love her handout for cardiac, and I'm going to give that to my class too. I think it's excellently, very well written, and I love the pictures. Is there any questions for anybody? Next week, remember, we have coming up our exam reviews. I'm doing mine early. I'm doing mine on Monday at 6 o'clock. Yes, it's going to be recorded. I don't know if the other class knows, but I do have a YouTube channel, Professor Bogart, Pediatric Nursing. And on that, you're going to see the review there first, even before Professor Morris, and she's quick, gets it onto your announcements. So it's always there for you and available. Also, if you need help with dosage calc, whatnot, that's also in there. You can go to my channel, get whatever you want. It's public. Anybody can go in there and look. I put it there and made it public because I'm not here to save my knowledge. Somebody can learn something, help a kid. That's all I want. Anyway, guys, it's been a pleasure.
Thank
And
you,
I will see
Professor.
you all. Have a good evening.